Kia ora, tēnā koutou, tēnā koutou, tēnā koutou katoa, ko Julia Slark aho. Kia ora and welcome. My name is Julia Slark and I'm the head of the School of Nursing at the University of Auckland in New Zealand, and I am the chair of the U21 Nursing and Midwifery Discipline Group. We are part of the U21 Health Sciences Group, which was established in the year 2000. The group was created to provide U21 staff and students with a framework for exploring opportunities for global collaboration in research, information exchange, and the sharing of resources across the health sciences sector. In order to celebrate 2020, the year of the nurse and midwife, the Nursing and Midwifery Group decided to develop and host a three-part webinar series titled Professional Nursing and Midwifery, Past, Present and Future. Normally, an initiative such as this would only be available to U21 university members. However, we felt really strongly, given it is the year of the nurse and the midwife, that this webinar series should be available to anyone who is interested to celebrate nursing and midwifery. And we would like to acknowledge all those who have contributed to the global response to the COVID-19 pandemic. This is the second webinar of the series, and we are very excited to present our webinar today, which is entitled Courage in Nursing, What It Looks Like and Why It Is Needed Now More Than Ever. It is now my great pleasure to hand over to our hosts, Professor Carol Hall from the University of Nottingham and Patricia Hibbard from the University of Birmingham. Tēnā koutou, tēnā koutou, tēnā koutou katoa. Over to you, Carol.
Good morning and welcome, everybody. My name is Carol Hall, as Julia identified, from the University of Nottingham, where I'm Professor in Nursing Education. I am delighted to be hosting this event today, and my job to start off with is to tell you a little about the programme and how it's going to run over the next hour, and then to introduce you to our speakers as we go through the hour. Just before we start, we have a little bit of housekeeping just to think about. You will find that there is a question and answer tool at the bottom of your screens. Please, could you use that to ask questions specifically? You will also find that there is a chat screen symbol at the bottom of your screen. If you could use that to communicate with each other, that's fine. But please, could you reserve your questions for the Q&A tool, because that makes it easier for Pat when she comes to collating the questions that you want to ask. Please do ask questions as the presenters are speaking. If you write them in the Q&A tool, then Pat will be able to pick them up and present them for consideration in the panel section later on in the hour. So do feel that you can type in your questions in the Q&A section. For your own experience and best viewing, it is best for you to set your Zoom to speaker view rather than gallery view, because you will then see the individual speakers more clearly and more effectively. Just to remind you that the webinar is streaming live to U21 HSG Facebook page, and that there will be a webinar recording available on the U21 HSG website at the end of the event. Do also remember, we can tweet, and it would be good to get a good Twitter stream running. So if you can use hashtag U21 Nursing 2020 to tweet about what you're hearing, and to tweet your questions if you want to as well, and get some discussion going on Twitter, that would be absolutely fabulous. So, courage, the title of our presentation seminar today. Courage is defined by Cummings and Bennett as being an attribute of nursing that enables us to do the right thing for people that we care for, be bold when we have good ideas, and speak up when things are wrong. Without courage, then, it is impossible to have nursing leadership, and impossible then to assure the unique global contribution that nursing and midwifery workforce is so important for them to be able to do. But what do we really understand by courage in nursing and in midwifery? We know that Florence Nightingale and Mary Seacole showed courage by standing up to authorities and championing for care. And we know of many others who have also been feted for their courageous activities in nursing throughout history. But what does courage look like today? And what should it look like going forward? How is courage helping nurses at this particularly difficult time in our lives to offer leadership and to improve lives for patients? Today's seminar will explore the concept of courage from three very different perspectives through the eyes of our eminent presenters and their work. So we will have three presenters, Dr. Gemma Stacey, Professor Caroline Bradbury-Jones and Seneli Lokeli, who will be presenting their perspectives of courage and in relation to influence and leadership and in relation to practice. At the end of the three presentations, you are invited to ask questions and to share your views with the panel. We need to move quite quickly, so I am going to move now to Dr. Gemma Stacey. Gemma is a mental health nurse and a principal fellow of the Higher Education Academy. In her work as an associate professor at the University of Nottingham, she developed an extensive portfolio of expertise around leadership, around clinical supervision, and around public health participation. Gemma has now moved to a new role as Director of Nursing Academy, Leadership Academy at the Florence Nightingale Foundation. And we are going to hear today about Gemma's new work relating to leadership and relating to the work of the foundation in supporting nurses and midwives during this COVID crisis. Gemma, it's such a delight to welcome you to speak today. I'm looking forward to your presentation.
Thank you so much, Carol, and thank you so much for the invitation to share with you the learning and the themes that have arisen from the Nightingale Frontline Leadership Support Service. Could we have the next slide, please? So to tell you a little bit about the service that we've been providing at the Foundation, first of all, this has been a remote leadership support service that we've offered to nurses and midwives at all levels of the organisation, from newly registered through to the executive team. And what we hoped to achieve was a forum where people could access support to process the extraordinary leadership responsibilities and challenges that they were experiencing in responding to the COVID-19 pandemic. It was important to us that this was a psychologically safe space for nurses and midwives, and also that it enabled strategies to be developed that would develop them as leaders and also focus on their self-care in response to the challenges they were experiencing and how they would move forward for this into the future. It was clear to us that it was important nurses and midwives could articulate their narrative, their story, that demonstrates how they had developed, how they had contributed to the COVID-19 response in order for them to adapt through the process and into the new world as we move into the next phase of response. Next slide, please. So just to tell you a little bit about the method we used in the sessions, as mentioned before, these were remote sessions. We had one of our leadership development facilitators and up to 6 members joining each group. And we took the group through a process that we call co-consulting. So this starts with one individual being identified as the client, and they share with us a particular problem statement. And then one member of the group acting as the coach, and they move through a process of clarification, exploration, and then finally we ask the client to turn off their camera and to listen to the whole group having a reflective discussion about what they've heard. And then we ask the client to return to the group and reflect upon what they heard and to make an action plan if that feels particularly relevant to that context. What we found was that these sessions were incredibly powerful. They offered a very unique space that practitioners weren't getting from other avenues. And the ability to listen to and to share perspectives from all different organisations across the UK within health and social care settings we created so many light bulb moments. It has been a real pleasure and a highlight of my career to date to be able to provide these sessions. Next slide, please. We also ensured that our facilitators were well supported. So every 2 weeks we had a group debriefing session. And what I'm able to share with you today is the themes that have arisen from those sessions, what's been challenging for the facilitators, and also how we could evolve the service we were providing continuously to ensure it was meeting the needs of the practitioners as we progress through the response to the pandemic. Next slide, please. We recognise that we are, as facilitators, in such a privileged position because we were providing these sessions to the whole range of nurses and midwives working across the organisational hierarchy. So we were gaining a really holistic picture of what the issues were. So as the senior leaders were sharing with us their challenges, we were hearing from the registered nurses, those working remotely, those that were shielding, how that was affecting them and the response to that. So we were able to reflect that back to the groups and gave us a very rich learning experience. Next slide, please. But relating to our particular topic today around the courage to influence, these are the themes that were most prominent. The first of those was the courage to be authentic. And this really related to the leaders at all levels, as I mentioned before, having the ability to be honest with their colleagues, with their teams, and to demonstrate their emotional intelligence. And that meant a commitment to sharing the emotions that they were experiencing and also being willing to notice and respond to the emotions that their colleagues and teams were experiencing too. We also heard about their courage to be transparent, and this very much related to being open with the information that people were gaining, but also where it was lacking. So rather than appearing to be holding all of the information and keeping it back from the rest of the team, the courage was to be transparent about how difficult that was and also where it was lacking for them. Also the courage to lead through uncertainty. And this was about acknowledging but also validating how challenging it is as healthcare practitioners to be working in a situation where there is little evidence to inform our practice, and constantly responding to changes in policy and processes as a result of that. And this idea of uncertainty really hit home. One of our participants said to us, perfect is the enemy of good. And they had to accept that perfect wasn't an option in this time. And we just had to sit with this uncomfortable uncertainty. Also the courage to challenge. And again, this related to the organisation across the hierarchy. So for leaders to advocate on behalf of their staff, but also to question where hierarchy was actually presenting barriers to good nursing care. And where there were situations within the clinical setting where policies and processes that were being dictated from a top-down perspective were impacting negatively on patient care, it was about the courage to challenge that and to do the right thing for the quality of care. Another theme related to the courage to role model, and that particularly related to how leaders were showing that they were enacting self-care and they were accessing supports of their team or additional support if it was required, and making sure that that didn't feel like it was a failure, but it was to enable us to be able to continue to sustain our response. And also finally, the courage to communicate. And that was about regular communication, authentic and honest communication. And sometimes that was information that was difficult to deliver, but the courage to be able to do that really did enhance the relationship that leaders had with their teams. Next slide, please. The influence of this was a culture of trust amongst teams and colleagues. It was openness, so people felt able to be authentic in their experience, but also a mutual understanding and appreciation of each other's role and the part that we were playing within the response. So there was a very collective approach to responding and to leadership. Next slide, please. As you might expect, we heard lots of examples where that level of courage within leadership was absent. And where it was absent, what we heard was that a command and control approach to leadership dominated. And this was very much dictated by a medicalised hierarchy. So what we heard was that nurses were excluded from decision-making forums, nurses and midwives, and where they would previously have been involved in those decisions, asked to offer their expertise. The shortcuts were being made, and those with the most senior positions within the organisational hierarchy were making those decisions. The implications of that was poor morale, not only for those senior leaders, but also for their teams, because they felt that they lacked the ability to have their voice heard. Those individuals felt undervalued as a person. They felt like they were a service that was being delivered, a number within the organisation, and not being recognised for what they could uniquely offer. One of our participants said that they, pre-COVID, felt like they were flying within the organisation, but during COVID, they felt that their wings had been clipped. This led to some resentment towards the organisation and a lack of commitment to continuing the level of investment that they had previously to that organisation. But very interestingly, it also started to create divisions between the teams. So the frontline staff were very much identifying themselves as having a different experience to those who were in the corporate workforce and not delivering the face-to-face care. And often quite resentful that those in that corporate workforce were protected from the high risk situations that those at the front line were putting themselves in, and not having that recognised or supported. And we also heard lots of examples of very disruptive team dynamics that were created as a result of this, and some very unprofessional behaviours, because people were finding ways of expressing their discontent and their challenges, but often in ways that were disruptive to the teams. Next slide, please. So a final thought from me is that we need to think about our next phase of courage, and that will be to re-exert our influence as nurses and midwives where a command and control agenda has taken over. It's been excused during this period because it's been talked about as our crisis response, but this can't continue. We've seen the impact that it's had in the short term on our workforce, and we need to act now to ensure that we either go back to our collective leadership approaches, or we reinstate them, or we move forward into those collective leadership approaches. Thank you so much for listening. I'm really looking forward to hearing your questions. Just for my final slide to say, if you have got any more questions that you want to contact me directly, my email address is here. And if you click on the link here, there's a page on the Nightingale Frontline service, and you can learn more about what that service offers. Thanks, everyone.
Thank you, Gemma. I now want to introduce you to our next speaker, who is Professor Caroline Bradbury-Jones, Professor in Gender-Based Violence at the University of Birmingham. Carrie is particularly interested in gender-based violence and domestic abuse, and has focused most of her work around the experiences of women. She is particularly interested in also, though, around how nurses and midwives respond to the challenges of working with domestic violence. Carrie's going to be sharing her research today into this area of clinical practice, and I look forward particularly to understanding some of the challenges faced in showing courage in this area. Carrie, it's lovely to see you here. Welcome, and I do hope that everybody will enjoy your session as much as I know I'm going to. Carrie.
Thank you. I'm not sure whether or not you can see me. I've got my video on. I can't see myself, but anyway, I shall continue until somebody puts it right. Yes, I'm going to talk about courage to have difficult conversations in relation to talking about domestic abuse, and how we can do the right thing, be bold, and speaking up the sentiments that Carol talked about earlier as being really crucial. And I'm going to use examples of some of the research that I've been involved with over the last number of years in relation to domestic abuse. And this is a particular area of interest and expertise for me, but what I want to appeal to everybody who's joining in with the webinar is to see how the issue of domestic abuse relates to you, wherever you are in the world, whatever your area of nursing, midwifery or healthcare practice, domestic abuse is a concern for us all. Next slide, please. Many people will recognize this symbol as one of the 17 Sustainable Development Goals that all countries are striving towards. And this is goal 5, which is concerned with tackling gender inequality. And amongst that is a goal to address violence against women and girls as a pervasive issue that is a global problem. So just thinking about domestic abuse itself, it's a broad term that refers to abuse that occurs within a domestic context. And it's very wide-ranging in terms of its different forms, but the most prevalent form is intimate partner violence and sexual violence. And that's really very much what I'm focusing on within this presentation. And in the UK, statistics are such that about 1.2 million women will be affected each year and 750,000 men. So it does transcend different genders. However, women and girls are disproportionately affected. But we will all know people either personally or professionally who are experiencing domestic abuse right now. And I want, as I said before, everybody to see the relevance to them as people and practitioners. Next slide, please. So just to think a little bit more about courage, as we are doing, and these are the words of David Whyte, a philosopher and poet, talking about courage as the measure of our heartfelt participation with life, with another, with a community, with a work, a future. To be courageous is not necessarily to go anywhere or do anything, except to make conscious those things we already feel deeply, and then to live through the unending vulnerabilities of those consequences. And what strikes me about that lovely phrase is the vulnerabilities of those consequences, because as I'll come on to say, there are big consequences in nursing and in midwifery of us not having courageous discussions about domestic abuse with the people with whom we're coming into contact. Next slide, please. So, what's the problem here? What am I talking about, and why am I concerned with courageous conversations in the context of domestic abuse? And there's some important points for us all to recognize. The first point is that people, women in the context of my work predominantly, very rarely recognize that their experiences are abusive. So a lot of abuse, well, all abuse is underpinned by coercion and control. And when people are controlled over and over again and told, for example, that they're fat, useless, ugly, etc., they come to believe it and live with it and normalize it and do not recognize that that is abusive. And most times, unless there's a severe crisis, most people do not disclose that they are experiencing abuse for a number of reasons: shame, concern about further abuse, concern about what will happen, concern about losing children, etc. A raft of different justifiable reasons why people do not talk about their experiences. But the problem is that as nurses and midwives and other health professionals, we're really concerned about broaching the subject with people. We're concerned about getting it wrong, about saying the wrong words, asking somebody about their experiences and them, in fact, not experiencing abuse at all. But the fact is, if we can talk about facts, a lot of research points to the fact that people, women, are not concerned about being asked. Even if their own experiences are not ones of abuse, reaching out in a safe and helpful and supportive way is not something that most people would be offended by. Most people welcome it. But what we have is a dynamic of silence between nurses, midwives, and the people in their care that can be very dangerous. Now, in the next slide, please, I'm going to present some quotes from our research. This is the first one. These are just small excerpts that are illustrative of the problem. This is what some nurses said that we interviewed in one of our studies. I think actually the middle classes are harder to ask about abuse, because I think that women in lower socio-economic classes don't care that you've asked. The middle class are somehow always argumentative about everything. So I think it's harder to ask them. Now, what this quote displays is a bias, an opinion about who it is that's likely to be affected by abuse, maybe, and who we ought to be asking about it. Whereas what has been demonstrated in research is that everybody's affected. Domestic abuse transcends geographical boundaries, socioeconomic status, ethnicity, race, etc. And the quote of "Oh sugar, what do I do now?" is actually by a midwife who illustrated just the problems that we face as nurses and midwives and health professionals when somebody does disclose to us. Do we know where to refer a person to? Do we know how to support them best? Big problems like that mean that we have a pervasive concern about the issue. Next part, please. And this is what some women have told us. And the first quote is really poignant, I think. These people, that's us, nurses, midwives, are supposed to be professional. They have to deal with telling people every day of the week that they've got cancer or something like that. They're used to dealing with bad news or difficult subjects, difficult situations. So what is their issue? And then the last quote is also from the same study and is similarly poignant. You see, if you don't know that you're being abused, you cannot tell somebody that you're being abused. And that goes back to my earlier point about how people themselves often don't recognize their own experiences as abusive. Next slide, please. And this slide I use to illustrate the fact that, again, from that same study, the women told us that in the same way as we talk openly about cancers, about breakages of bones, and we display that and we say, here, this is what is going on inside, there was an appeal from the women in that particular study to say, please talk to us about domestic abuse. Please tell us that you're concerned about us, and please help us to recognize that this is what's going on for us, and then we can do something about it. Next slide, please. Now, what I'm saying, in effect, is that as midwives, nurses, health professionals, we sometimes get it wrong. We sometimes don't act in the way that is helpful. We don't care to talk about the issue, but we shouldn't be hard on ourselves, because what is demonstrated now in quite a few studies is that we are not very good in our professions at preparing the next generations of nurses and midwives. And this is, again, just one excerpt from a study that you have the references for at the end of the presentation. This is study number 2, where we interviewed student nurses and midwives. And this is just one quote from very many. I think it perpetuates itself, because if we leave, that's our professional programs, not being prepared, then we're going to feel embarrassed or not sure how to talk to our students about it. And then that's probably why they, registered nurses, why they don't talk about it, because they feel, oh, it's this thing that I should know stuff about, but I don't. And so this is the cyclical state of silence, if you like, within our profession, and a failure to prepare subsequent generations of nurses and midwives. Next slide, please. So what's important then is that we are courageous enough to talk about domestic abuse. And Patterson and colleagues have these 3 dimensions where they say that crucial conversations are ones that operate within a context of opposing opinions, strong emotions, and high stakes. I'll come back to that in a minute. But as nurses and midwives, we are absolutely crucial in having those crucial conversations, in asking people whether they're okay, and showing a concern for people when we suspect that they may not be okay. And we can in that way break those cycles of silence, and we can build nursing students and midwifery students awareness and confidence in having courageous conversations. So what about those high stakes that Patterson and colleagues talk of? Well, in the context of domestic abuse, the stakes of asking somebody about domestic abuse and getting it wrong are really very low and unlikely. The stakes of not asking somebody about their welfare, passing over something where we feel that there may be something amiss in somebody's lives and they may in fact be experiencing abuse is of an extremely high stake, because domestic abuse has long-term consequences on health, mental health, well-being, and it is lethal. And in the UK, at least 2 women every week die at the hands of an abusive perpetrator. Next slide, please. So coming on to the end of my presentation now, I just want to think about, well, why is this relevant now more than ever? Because that is in the title of the presentation. And I want to just refer to this piece that my colleague Louise Isham and I wrote for the Journal of Clinical Nursing right at the beginning of the pandemic, where we were proposing that some of the measures around lockdown were going to be catastrophic for some people who were locked into abusive relationships with partners. And that was a tentative inquiry at that point, but unfortunately what we've found, again, this is a global picture, is that domestic abuse rates have soared during the pandemic. And so it's now more than ever that we need to be fine-tuned to what is going on around us, be hyper alert to people within our families, our colleagues, and the people in our care. And particularly as we're coming out of lockdown, where we may be coming into face-to-face contact with people again, that we need to keep that hypervigilance and be prepared to have courageous conversations. Next slide, please. So I think it's important not to leave the presentation with a request to do something and not provide the resources whereby we can learn how to do that. So this was a U21 Health Sciences Group funded piece of work. Thank you and acknowledgement to them, where we've put together an open access resource that Karina will make available, the link as part of this presentation. This is a resource basically developed with students in mind, with healthcare students, and it was developed with them. But I would say that if you're wanting to have more insights into how to have courageous conversations about domestic abuse, whether you're a student or a registered practitioner, please do have a look at the resource. It's there for you to view. And next slide, please. These are the references to some of the bits of work that I've alluded to, and if you want to access them and have some more reading around them, then the references are there for you to do so. And I'm really looking forward to the questions and discussions that follow, so thank you so much for listening to me.
Thank you, Carrie. Your illustration of courageous conversations has so many applications, but it is so useful to be able to see how they manifest very practically within a clinical setting such as yours. So I'm delighted that you were able to share your presentation, and I know that there are going to be so many questions in the question and answer session for you. So I look forward to that too. So our third speaker is Saneli Lokeli from South Africa. Saneli is a midwife, and she has really embraced influence throughout her practice, both as a student of nursing midwifery and then into her registered practice role as a midwife. Saneli established the South African Nursing Student Association with an aim to unite students across South Africa. And she was recognised by the Mail and Guardian as one of South Africa's 200 young people in 2018, and for her influence. I am proud that Saneli has decided that she is happy to come and present and share her perceptions of courage to overcome convention. And I'm looking forward very, very much to hearing what Saneli has to say, and I'm sure you are. Saneli, welcome.
Thank you so much for having me. You can go on to the next slide, please. When I saw the theme for today's webinar, I immediately thought of Albertina Sisulu. Albertina Sisulu, as affectionately referred to as South Africans, was the wife of Walter Sisulu, who was the best friend and mentor of the late former President Nelson Mandela. Sisulu embraced and embodied the traits focused on in today's webinar. She was a frontline worker during the apartheid era. Stories have been told by the community she served about how this lady always carried a suitcase. During the peak of apartheid and the unrest in the streets of Soweto, she had the courage to leave the safety of her home in order to offer maternity services to her community. She carried a suitcase full of her apparatus on her head because she walked to her patients. Whilst tending to women in desperate need of maternity services, she would discreetly use this opportunity to encourage them to join the liberation struggle. She used her position as a nurse and a midwife to influence politics on the ground. She is truly the embodiment of courage. Please go to the next slide. It's not the first time in history that nurse midwives find themselves in extraordinary circumstances and having to make extraordinary decisions. In the book of Exodus, we read about a time when Pharaoh, the king of Egypt, ordered for the mass killing of newborn Hebrew babies. Midwives chose to abstain from this order and continued to save lives. Just like Masisulu, these midwives exercised courage, leadership, and autonomy in the midst of difficult circumstances. The traits seen in Masisulu and the midwives found in the book of Exodus ring true for many midwives around the world during this devastating pandemic of COVID-19. We are seeing this courage in the nurses and midwives who leave the comfort of their homes daily to face the virus head on in our hospitals. Nurses and midwives are displaying the highest level of leadership and ethics. Subsequently, the conduct of our nurses and midwives has given the tarnished image of nursing in South Africa a facelift. More and more South Africans are starting to find value in the work done by nurses and midwives. This has boosted the morale of nurses and midwives. This has given them a sense of belonging. For the first time in my career as a nurse this year on International Nurses Day, we saw positive stories about nurses being told by South African media on various platforms. Perhaps this comes at just the right time, as 2020 has been declared as the year of the nurse and midwife by the World Health Organization. Please move to the next slide. The COVID-19 pandemic has presented the midwifery profession in South Africa with an opportunity to take the profession back from the obstetricians. In the recent past, most women with medical insurance opted to birth with an obstetrician in the hospital. However, we are now seeing a shift in how women choose to birth. The pandemic has put a spotlight on midwifery-led care as a safer option for birth. As women and their families avoid the hospital in fear of contracting the virus, home birthing has become a prevalent option amongst pregnant women. Just like Masisulu, midwives who are practicing privately have had to step out of the comfort of the birthing unit and carry their suitcases and go to women's homes to deliver babies. This is a victory for midwifery in a country where birth is increasingly becoming medicalized and nurse midwives are losing their autonomy as they practice as obstetric nurses. The increased demand for midwifery-led care is also welcomed in a country where the private sector has a cesarean birth rate of 60% as opposed to 26% in the public sector. Now is the opportune time for midwives to really take back the profession. Next slide, please. During this time, where there is a resounding call for social distancing, midwives don't have that luxury. I remember when I was in labor just a few months ago, my midwife and doula hugged me, rubbed my back, encouraged me as I was in pain, and allowed me to lean over their bodies when I was experiencing excruciating contractions. Midwives cannot use an on and off switch to stop women from birthing. Midwives cannot adhere to social distancing or physical distancing during birth. This is by no means a call for midwives to be reckless when rendering care to expectant mothers and their families. It is, however, a call for nurse midwives to continue to practice Ubuntu in the face of this pandemic. Ubuntu is an African philosophy which has played a major role in the history of caring. Roughly translated as human kindness, Ubuntu is often interpreted as humanity towards others. Ubuntu says, I am because you are. Ubuntu as a philosophy gives us courage. Ubuntu ensures cohesiveness and solidarity. Ubuntu encourages participatory decision-making. We have seen how nursing associations and unions have courageously raised their voices to advocate for our profession by holding governments accountable for ensuring the safety of nurses and midwives who are at the coalface through the provision of personal protective equipment. When nurses and midwives feel safe, then they can continue to courageously practice Ubuntu as they render life-saving care to patients whose families can't even visit them in hospital during this time. Next slide, please. Although South Africa is a developing country, nurses and midwives continue to improvise and stretch the resources during this time. As many pregnant women around the world are experiencing feelings of grief as they grieve the experience of a normal pregnancy in a COVID-free society. Nurse midwives have come up with innovative ways to ensure that women don't miss out. Nurse midwives are taking to Zoom and Skype to offer antenatal classes for families and their partners. Nurse midwives are giving health education through WhatsApp video calls. Birthing centers are providing virtual tours for expectant parents. Nurse midwives are proving to be resilient and flexible under these trying circumstances. Nursing and midwifery associations and unions amongst African countries are also taking to virtual platforms to share information on how to strengthen nursing and midwifery services during this pandemic. Nursing and midwifery leaders in Africa are using their influence through the East, Central, and Southern African College of Nursing to influence policy making at continental level. This partnership and sense of community demonstrated by African countries is the essence of Ubuntu. Next slide, please. While we wait for a safe vaccine, we need to align our care protocols to a world where COVID-19 is a prevalent virus. This implies that policymakers in countries need to equip their health systems by increasing their human and material resources. Policymakers in countries which are hard hit by this virus, such as South Africa, need to benchmark their healthcare systems with those countries that have managed the infection well. This in turn will make our health systems resilient in case of another pandemic in the near future. Nursing and midwifery lecturers need to conduct research and teach students about pandemics as well as COVID. As nurses and midwives in practice, we need to learn from our current experiences so that we can prepare for the future. Thank you so much.
Saneli, thank you. Sorry, I'm just getting my video back on there. Saneli, thank you for a really thought-provoking presentation and an inspiring one, showing us a very positive way forward in light of COVID and in light of the challenges that are faced by so many people across the world. I have a question for you about how the philosophy of Ubuntu may be taken more globally, but I know that Pat is wanting to go on to questions and answers, so I'm going to ignore that one for now and introduce Pat.
I have to go back on and the cats.
Okay.
Okay.
So interesting one there. So Pat, would you like to take the questions and answers forward now, please?
Lovely. Thank you, Carol. And thanks to all of our speakers. What fantastic presentations that you've made. And of course, they've evoked a few questions that have come through. And I'm going to start, first of all, with a question for Gemma. And I think, Gemma, a question came up around the challenges or the miscommunication and the difficulties of communication during the, I think, between staff and perhaps between organisations as well, during the COVID crisis, and as you know, a lot of students have been deployed out into areas and had extended placements, and it was within the context of that really just the challenges of the communication and getting it right for students. So I suppose the question is, are there any ideas or recommendations about how communication could be improved during times of uncertainty?
So I heard lots of examples of where this was handled really well. And I think, as I said in my presentation, one of the themes was around frequent and honest communication. So we heard lots of examples where directors of nursing were having daily briefing sessions with the whole of the staff team could call into as webinars, and they would give them up to the minute information as they were receiving it, but also being very honest about where that information was still lacking or where there was uncertainty within it, and to support that, then providing the right kinds of forums throughout the organisation where people could express their discontent with that uncertainty, so they were able to hold it, sort of contain it, and appreciate that it is absolutely not perfect and not the way we would want it to be, but by being very transparent and being very authentic, it enabled the staff to feel that sense of trust in their leaders. So I think the challenge has been often that the information hasn't been withheld, it just hasn't been there. And that's been very difficult for a lot of leaders to feel able to be open about.
Because they haven't had the information themselves to communicate. Yeah.
That's brave enough to say, actually, I don't know either.
Yeah.
Where you saw that real courage.
Yeah. That's great. Thank you. So I guess leading on for that, another question, Gemma, and I think it kind of links in really in terms of that communication issue, is what are your plans to ensure that your research is going to challenge and, going forward is going to influence the command and control structure and improve communication through organisations?
So our intention is to share our learning from the Nightingale Frontline sessions widely. So this wasn't undertaken as a piece of research, it was a service development, and what I presented to you today is the themes and reflections of those that have been facilitating those sessions. But we feel that we've got an obligation now and an ethical responsibility to share that learning widely, so that we can not only identify where the nursing and midwifery leadership has really contributed to a very collective and cohesive culture that has enabled staff to sustain these high levels of emotion and fear and concern in a way that they still feel very committed to their organisation and to the profession, and similarly where that's been lacking and what the consequences of that has been. So we're working in collaboration with the King's Fund around a particular project that's looking at how staff stress and well-being is influenced by the nature of the leadership within that organisation, and feeding all of our learning into that piece of work. That's been funded by the RCM Foundation, and will provide recommendations for other organisations where they haven't been able to sustain that collective approach. And I guess just for people that are listening, if people are interested in this concept of collective leadership, the King's Fund has lots on their website that various different leadership consultants and experts in that area have written about the particular topic. And I think what's really interesting about it is that this is not about nurses and midwives asserting their individual expertise. It's about offering their expertise to the collective leadership within that organisation and sharing responsibility for that. So this is not about people working in silos or being protective about their particular areas. It is about really enforcing the benefits of a shared responsibility and a shared agenda, and where there is a vision that is collectively developed, that the objectives of that vision are shared amongst the whole organisation.
Thank you, Gemma. That's really interesting. Just moving. I'm going to move on now to a question for Carrie. Just conscious of our time, but thank you very much for a very full answer there. Carrie, a question for you. Within the BAME population, there's a lot of domestic abuse existing, especially now. And women have the fear of being reprimanded, stigmatized or rejected by friends and families. And it may affect women's willingness to speak out. How can you help begin the process of having difficult conversations with such women? They may look okay, but they're not okay.
No, thank you for that question. It's a really pertinent one to raise. And I think a good starting point is to recognize that although domestic abuse is, as I said in the presentation, something that's pervasive and affects all populations across the world, it's experienced differently within different populations. So a starting point is to understand that within BAME communities, not only are domestic abuse levels reported to be higher, particularly at this current time, because there was a lot in the media about that. It's to understand respectfully what that looks like within different communities. So by no means to other, but to listen to people's accounts and to undertake research that highlights the particular issues affected. So in my presentation, I read out a couple of accounts from women who taken part in a particular study. And in that study, we interviewed women from BAME populations, and what they told us firsthand was, yes, we experience domestic abuse in very perhaps different ways in some contexts. So for example, the experiences of abuse within a broader family network as opposed to from an intimate partner were a real problem for a lot of women, and particularly, for example, from brother-in-laws or from mother-in-laws who were the perpetrators of abuse in that context. So it's very particular forms of violence. And the issue around stigma and shame seem to be exacerbated within certain populations. And I think, again, that's a really good thing to understand. And then also to understand about the specific resources that are available for women and men from BAME communities, such as the Southall Black Sisters, for example. We worked with Shakti organisation, which is a particular organisation to support Asian women. So there are resources out there that are specifically for BAME populations. And I just, if I could, respond to the question that was posed by Julie in relation to resources. And again, a really relevant question to ask. The sector is grossly under-resourced and is very stretched. So the question about, is it ethical, or what are the ethics around asking, having those crucial conversations and then not having any referral points, is to say although resources are stretched, there are resources available. So from a nursing point of view, midwifery point of view, it's about knowing what resources are there, and also to lobby as part of our professional role, to lobby. So if we are aware that there's a gap in services, then it's our call, I think, to join in any lobbies to support them. And yeah, I think I'll leave it like that, because maybe there might be some other questions, but no, thank you for those questions. They're very relevant and useful.
Thanks, Carrie. That's great. Thank you. And I'd like to now move to a question for you, Sonali. So I guess the question is, I mean, your presentation was inspiring about how really midwifery practice is moving forward, always, is moving forward within the current pandemic. But I guess there was a question about your drive. What was your drive to set up the South African Nurses Student Association to raise the profile of nursing? Because it's quite connected really with what you're discussing today.
In South Africa, we have a degree program for nursing and a diploma program for nursing. there was a time when the degree program was facing a lot of backlash from one of the ministers of health at the time. And he thought it was useless to have degree nurses. So then we had to come together and form a structure that would be a voice for all the degree nurses to defend our qualification and to say the rest of the world is moving to the degree nurse direction. Why do you want to take us back? So was why the main reason we formed the South African Nursing Students Association at the time. Needless to say, the country has moved forward. We are phasing out the diploma qualification, and all registered nurses and midwives will now be degree nurses.
Fabulous. And is that helping you now with what you're doing now, the learning from that development?
Yes.
Is that, yeah.
Yes, definitely. Because right now, as an academic, I work with nursing students. So it has helped me as an academic to understand students at the ground and to always take their concerns seriously.
Brilliant. Thank you. Thank you, Sanani. That's great. And just a final question, I think, for Carrie. Carrie, again, thank you again for your inspiring talk. What advice and recommendations would you give to people in domestic abuse situations to protect themselves and seek help during the pandemic?
Oh, that's a very good question. To take advantage of the helplines, and I can post the helpline on this chat if it's helpful in any way. Most countries will have helplines for domestic violence. Certainly in the UK, we have a very well established and very well utilised domestic violence helpline. And what is indicated during the pandemic is that women and men have used the online discussion facility more than calling up, because if you're in a lockdown situation with an abusive partner, it's very difficult to get on your mobile phone, but you can always sneak into the bathroom with your phone and log on in a way that's more discreet. So and if you are somebody who's experiencing domestic abuse, then to have the courage yourself to reach out to somebody who's trusted, maybe in our context, a trusted nurse or a trusted midwife, and somehow get access to them, which Pat is posing the question, is very difficult to do, because as I've said, most people do not do that for a lot of fear, but try and find the mechanisms through either formal support on helplines or finding somebody to trust who you can confide in.
Thanks, Carrie. That's really helpful. And I think that's really the open questions we've got at the moment. So thank you to all our panelists for fantastic presentations and also responses to the questions that have been raised. And I'll pass back to Carol really just to close.
Thank you, Pat. So this morning we have heard from our experts. We've heard about the courage as an attribute of nursing that enables us to do the right things for the people that we care for. And Carrie, I think, has illuminated the need to do the right things for the women and the families in the research area that she is looking at. Saneli has talked about doing the right thing through Ubuntu and maintaining Ubuntu through very challenging circumstances. And Gemma has talked about the challenge of speaking out when things are wrong and for being bold when you have good ideas. So when you're taking back to the original definition of courage, I do believe that we have really unpacked a lot of the ideas that were voiced as an original definition by Cummings and Bennett in 2012. But we've done so much more than that by illustrating and colouring in different ways the rich depth and expertise, the rich tapestry of expertise that we have within nursing, and the many ways in which we can take nursing forward by being courageous and having those courageous conversations. As a final thought to leave you with, The true courage, said the Wizard of Oz to the lion, is in facing danger when you are afraid. This is what nurses are doing, midwives are doing many days of their lives, and sometimes without even being aware that this is going to happen to them, except on a very immediate basis. This is what we are experts in, and this is what we should develop and we should be proud of. As nurses and midwives, we are courageous, and we're courageous in so many different ways, but our biggest attribute is in facing danger when we ourselves are afraid. Thank you very, very much. Okay, so just to finish off then, today's webinar will be available on the U21 Health Services Group website. So I think that Karina's there put the link up for everybody to do that. If you have questions that you would like us to follow on with, adding in the questions and answers and chats, we'll make sure that you get the contacts, those questions to those people who need them, so they can help furnish you with answers. Thank you ever so much for participating today. I hope you found it interesting and informative, and hopefully we look forward to seeing everybody again soon at our third webinar. Watch this space. You can see Julia smiling there. Definitely watch this space because we will be holding a final seminar this year as part of this celebration. And again, it will be open to everyone to join in and celebrate this International Year of the Nurse. Thank you everybody for your time.
Kia ora. Thank you very much.